Hello, my name's Dr. Ayman Shamil.
Hi, I'm Dr. Praful Ravi.
Today we're going to talk to you about a real patient who had confusion, lethargy and shortness of breath. We'll discuss the causes and treatment of his hyponatremia or low sodium. A 73-year-old gentleman presents with a 4-month history of shortness of breath, lethargy and confusion. He has a past medical history of chronic obstructive pulmonary disease and is a heavy smoker. On examination, his oxygen saturations were 94% on air. He had a tachypnea with a respiratory rate of 24 and reduced breath sounds in the right lower zone of his lungs. He didn't have any peripheral edema and his jugular venous pulse was 3 centimeters. His investigations demonstrated a hemoglobin of 12.4, white cell count of 8.5 and platelets of 350, all of which are unremarkable. His sodium level was 127, which is low, and his potassium was 4.5, urea 5 and creatinine 80, all of which are normal. His serum osmolality was 255, which is low. His urine osmolality was 250 and his urine sodium was 50. His chest radiograph demonstrates a radio-opaque lesion in the right hilum. So Praful, what are the causes of hyponatremia?
So, Eamon, the first thing I always like to think about in hyponatremia is medications, because these are the commonest causes, or this is the commonest cause of hyponatremia. The most important medications to think about are diuretics, like loop diuretics such as furosemide, and thiazide diuretics such as benzoyl-flumethazide. These dehydrate you and cause you to lose sodium and water in your urine, hence leading to hyponatremia. Now, in this gentleman, we didn't have a medication history, so I think the next thing we need to do is to consider plasma osmolality. Plasma osmolality is a measure of how concentrated the blood is. So it's basically a measure derived from calculating the amount of solutes you have in your blood. This can either be high, low or normal, or hypertonic, isotonic and hypotonic, and the values are listed on the screen, and the units for these are in milliosmoles per kilogram. Now, in this gentleman, from memory, we had an osmolality in the plasma of 255 milliosmoles per kilogram. So this gentleman has a hypotonic hyponatremia, and hypotonic hyponatremia is actually the commonest cause of hyponatremia after diuretics. When dealing with a hypotonic hyponatremia, you need to think about the volume status of the patient, whether that's low, normal or high, so hypovolemic, euvolemic or hypervolemic. Hypovolemic simply means that someone is dehydrated. They don't have enough fluid in their body, so they have dry mucous membranes, they have reduced skin turgor. Euvolemic means they're relatively okay, and this gentleman, remember, we didn't have any peripheral edema and the JVP was normal, so this gentleman was euvolemic. Hypervolemic means that the patient is fluid overloaded, so they would have edema, they might have crackles in the lungs because of pulmonary edema, and they might have a raised JVP. So, this gentleman had a hypotonic euvolemic hyponatremia.
Given this information, what's the most likely diagnosis, Praful?
So the most likely cause of a hypotonic euvolemic hyponatremia is a condition called SIADH. SIADH stands for Syndrome of Inappropriate Antidiuretic Hormone. If you remember back to physiology, antidiuretic hormone is produced by the posterior pituitary and acts on the distal tubules of the nephron to reabsorb water. So its functions are to reabsorb water and hence regulate plasma osmolality. What SIADH means is that there is too much of it being produced and is being produced inappropriately. And the criteria for getting the diagnosis of SIADH are several. They include having a low plasma osmolality, like we mentioned. They also include having a raised urine osmolality of greater than 100. Now, this is because if you're reabsorbing water from the urine and from the distal nephron, your urine becomes more concentrated. They also require a patient to be euvolemic, as in our case. And they require a continued natriuresis, so a continued excretion of sodium greater than 40 millimolar. Importantly, also, there are a couple of important things that we need to ensure that we need to sort of rule out, and that is we need to have normal thyroid and normal function, so a normal TSH and a normal cortisol, because both these hormones can interfere with volume and fluid retention and excretion. And finally, they need to, in order to obtain a diagnosis of SIADH, there needs to be no recent diuretic use. So in summary, this gentleman most likely has SIADH, syndrome of inappropriate antidiuretic hormone.
What are the causes of SIADH?
So the causes of SIADH are a few important causes that you need to think about. The most important cause is malignancy. Malignancy, in particular small cell lung cancer, is the commonest cause or one of the most important causes of SIADH. Small cell lung cancer is a type of a neuroendocrine type of lung cancer where the lung cancer cells have some sort of aberrant genetic makeup and cause them to produce excess levels of ADH, antidiuretic hormone, hence getting SIADH, or an inappropriate production of antidiuretic hormone. Other causes include other lung disease, so non-malignant lung disease such as infections, simple pneumonia, TB, maybe even cystic fibrosis. Cranial disease is another important cause because ADH is produced by the pituitary, so anything that is dysregulated in the brain, for example, brain trauma, brain hemorrhage, brain surgery, can also lead to SIADH. And finally, psychotropic drugs, particularly things like antidepressants, SSRIs, and antipsychotics, are also important causes of SIADH. But in this gentleman, we can really rule out the absence of drugs because we weren't given any history of medications. We can rule out cranial disease because he didn't have any history of confusion or sort of organic brain disease. And given the smoking history and given the chest radiograph findings, I would say that this gentleman has a very high probability of a malignancy in the lung, most likely a small cell lung cancer, which has caused the hyponatremia via SIADH.
What is the treatment of SIADH?
So the treatment of SIADH is relatively straightforward. The most important thing, as you might intuitively think, is to treat the underlying cause. So whatever the cause is, whether it be a lung cancer, whether it be an infection, whether it be stopping the medications which you think are causing the problem, the most important thing is to direct your treatment at that. In the meantime, because while you're working out what the cause is, or while the treatment for that is starting to take effect, or while you're waiting for that treatment, one thing that you could do is to fluid restrict a patient. This typically involves restricting their fluid intake, depending on what their size is, to between, say, 500 millilitres to 1.5 litres of water a day. The way in which this works is that you're basically rendering a patient hypovolemic and hence bringing the sodium up by reducing the amount of water there is in the blood. There are other treatments that have more recently come onto the scene. These are vasopressin receptor antagonists. So vasopressin receptors are found in the distal nephron and are the receptors by which ADH, which is also known as vasopressin, acts on. So these antagonists, such as tolvaptan, competitively block the receptor and hence prevent ADH in the blood, in the bloodstream, in the plasma, binding to these receptors and causing its effects. So we've got a number of options here whilst we're waiting for the cause to be elucidated in order to try and treat the patient's low sodium. However, the important thing to remember is that one shouldn't increase the sodium level too quickly. You should aim for about a rise of sodium for about 10 millimoles per day. The reason for this is that over-rapid correction of hyponatremia can lead to a condition called central pontine myelinolysis. So just to summarise what we've talked about today, the commonest cause of hyponatremia is diuretic use, such as furosemide and thiazides. Whenever you're confronted with hyponatremia in real life and when dealing with a patient, think about what their osmolality is and also think about what their volume status is. And lastly, SIADH, syndrome of inappropriate antidiuretic hormone, is an example of a euvolemic hypotonic hyponatremia. And the commonest causes of these are malignancy and lung disease, and the most important way to treat it is to treat the underlying cause. Thank you very much for listening.